Viral infections round out the etiologic picture of aplastic anemia. Human parvovirus B19 is particularly notable and mechanistically well understood. This virus has a highly specific tropism, meaning it selectively targets and infects erythroid progenitor cells, the precursors dedicated entirely to producing red blood cells. In an immunocompetent person, parvovirus B19 causes a transient red cell aplasia that resolves once the immune system clears the virus. However, in someone with an underlying hemolytic anemia, such as sickle cell disease, the situation is far more dangerous. These patients depend on an accelerated rate of red cell production just to maintain adequate hemoglobin levels. Even a brief interruption of erythroid output can precipitate a dangerous aplastic crisis because the marrow cannot keep pace with ongoing red cell destruction when production is simultaneously halted by the viral infection. Hepatitis C virus is another recognized infectious trigger for aplastic anemia. This means that in any patient presenting with new-onset pancytopenia, viral serology, including both parvovirus B19 and hepatitis C, should be incorporated into the diagnostic workup alongside bone marrow biopsy and all other standard investigations. These viral causes should never be overlooked during the evaluation. Several viruses are implicated as rare but important causes of acquired aplastic anemia, AA, with the most substantial evidence for hepatitis viruses, especially non-A, non-B, non-C hepatitis, Epstein-Barr virus, EBV, cytomegalovirus, CMV, and human immunodeficiency virus, HIV. The pathogenesis is thought to be largely immune-mediated, where cytotoxic T lymphocytes target hematopoietic stem cells through mechanisms such as molecular mimicry following viral infection. Direct viral cytotoxicity is less clearly implicated, except in parvovirus B19, which primarily causes pure red cell aplasia or aplastic crisis in hemolytic anemia rather than typical AA. Hepatitis viruses, non-A, non-B, non-C, distinct association, often in young males, with AA developing 1 to 2 months after acute hepatitis. Most cases are seronegative with immune mechanism suspected. Epstein-Barr virus, EBV, and CMV, rare but distinct. AA may occur during or shortly after acute mononucleosis or CMV infection, likely via immune-mediated marrow injury. HIV and HTLV1, documented as triggers for marrow failure via immune dysregulation or increased susceptibility to other marrow-suppressing infections. Parvovirus B19 primarily causes transient aplastic crisis or pure red cell aplasia in patients with underlying hemolytic disorders or immunodeficiency. Chronic infection leads to severe anemia due to direct RBC precursor destruction, but classic AA with pancytopenia is exceptionally rare. In the next video, we will talk about treatment of aplastic anemia.